Hello and welcome to this edition of To Your Health. I'm Candy Szymanski, the Chief Operating Officer at Marlborough Hospital. Today we're going to spend some time talking about the expansion of surgical services at the hospital, and I'm thrilled to have Dr. Cohen with me today, and I'll tell you just a little bit about him. You know, we all know that needing surgery is very stressful in itself. But I think if you add to that the fact that you have to travel to have the surgery done, that can certainly be some additional stress for you as well as your family. So Marlborough Hospital has partnered with UMass to bring some additional surgical expertise to Marlborough Hospital, and they have tapped Dr. Philip Cohen to be the first surgeon that they're sending to the hospital to expand the service. Dr. Cohen's office will be located in Southborough at 28 Newton Street, and we are right now hoping that around October 1st, which actually dawned on me is not very far away, he will be here and begin to see patients. Now with that, I should tell you that he's been certainly covering call and he's been operating on patients at Marlborough for the last several months, and we've been very thrilled to have him. Dr. Cohen is a graduate of Boston University School of Medicine and completed his residency at the Boston University Medical Center. You did an additional fellowship in surgical research and minimally invasive surgery, which we're going to talk about. Where was that fellowship?
The fellowship was at BU as well. Was at
BU. So you are an expert in laparoscopic and minimally invasive surgery. I hope to talk a little bit about the difference. And then we're going to talk about, you know, hernia repairs, gallbladder disease, GERD, and what as a surgeon that you do for those. So I wanted people though to know that you also specialize in bariatric surgery, which we won't have the time to spend on today, but I hope to get you back very soon so that we can talk about that wonderful weight loss alternative for people. And but I'm really thrilled to welcome you here today. I always like to start, Dr. Cohen, by asking, why did you choose to be a surgeon?
Well, Candy, first of all, thank you for having me, and I really appreciate the opportunity to be here today. I got into medicine as a sort of a life calling. My grandfather was a physician, and he unfortunately passed away before I was born. But my mother kept on saying when I was growing up, you're going to be just like your grandfather, and lo and behold, I am. Now, he was a pulmonologist. I chose surgery. And I chose surgery because I really enjoyed the immediacy of the results. I really enjoy the fact that I can perform a surgery and see an immediate result in the patient, either if it's reduction of pain or fixing a hernia or helping people with their acid reflux or even weight loss surgery. So I really enjoy all of those things.
But, you know, your lifestyle must have changed dramatically. Once you started your residency, probably through fellowship and now. When you're on call, there's not a whole lot of sleep, and right, you must be pretty busy. And I happen to know you do call at more than one hospital. So right. How do you juggle all of these things?
Well, it first starts with a very understanding wife. And I should really say that it's not nearly as glamorous as you see on TV. It's a lot more downtime, and I do get a lot more sleep than at least I used to when I was in residency. But you know, it requires really a very good focused team. It's actually not just an individual effort. Even though I'm the one on call, I still have the team of either, if I'm talking about UMass, the residents in the hospital, or if I'm talking about Marlborough Hospital, the physicians that are in the hospital, the nursing staff. So it takes a lot to kind of take really good care of patients.
Now, I want to understand there's laparoscopic surgery, there's minimally invasive surgery, and for lack of a better term, because I don't know what to call it, old-fashioned sort of open surgery. I don't know if that's the right term. So what is the difference between open surgery and laparoscopic surgery?
So I'm going to probably jump to the last part of the answer, which is minimally invasive surgery is a group of techniques across multiple different disciplines that includes laparoscopic surgery. And the difference between laparoscopic surgery and the traditional general surgical open procedures is that laparoscopic surgery offers smaller incisions, better patient recovery, an earlier return to work, and sometimes better outcomes.
But you, so when you do open surgery, you're looking right down into what it is that you're working on.
Correct.
That's not how you do laparoscopic or minimally invasive surgery. So how do you see what you're doing? So
we use cameras, and actually the cameras are very technologically advanced these days. They're in high definition with 1080p resolution, which is the best that you can get on any television at the store. The cameras themselves are hooked up to a lens system, or sometimes these days we're using even more technologically advanced chips on a stick, sort of like your digital camera on the inside of the abdomen. And these lenses go through a small plastic opening that we place through the abdominal wall, and we can see in high definition what's going on. And on top of that, the other advantage of laparoscopic surgery is that the image is magnified 1.5 times compared to the human eye. Is that better, the magnification? Does that help you, or? Absolutely. Now, did you have to make the transition from open surgery to, I mean, well, actually today there still might be patients where you do open surgery versus laparoscopic. Correct. There are certain patients that are not suitable for laparoscopic surgery, and I can get into details about that as well if you'd like, but there's also certain procedures that are not appropriate for laparoscopic surgery. For example, a lot of trauma, for example, should not be done laparoscopically because patients have an immediate need to control bleeding or control a source of infection. So sometimes you have to do open surgery these days, but I'm happy to say that with advanced training, surgeons can now offer patients the ability to have laparoscopic surgery for just about anything. And then you said the difference between laparoscopic and minimally invasive is the type of instrument? No, so minimally invasive is sort of an umbrella under which laparoscopic surgery would fall. Minimally invasive surgery also includes arthroscopic surgery for orthopedics, or even robotic surgery would fall under minimally invasive surgery. There's minimally invasive spine surgery techniques as well. So there's a lot that falls under that minimally invasive surgery umbrella, but laparoscopic surgery is really the more general term for the general surgeon and the procedures that we do in the abdomen. So with abdominal surgery, because I'm an old nurse, patients had, you know, the incisions were large, there was a lot of muscle that was cut, the healing took several months. How does this change all of that? It changes drastically. So one of the points of laparoscopic surgery is to minimize not necessarily the length of the incision, but the trauma to the abdomen. The abdominal wall is actually split instead of actually being cut using these newer trocars that we have. A trocar is the plastic tube that goes through the abdominal wall to allow passage of instruments. We blow the abdomen up with carbon dioxide. It's very easily absorbed, and so that's why we use carbon dioxide. And it blows the abdomen up, giving us enough room to work. In the old-fashioned technique, the muscle is cut, and therefore that has to heal, whereas in the new technique, the muscle is split, and so it closes down very easily. So right away, that has to take, a lot of the discomfort out, and most, several weeks off the recovery time, I would think. Absolutely. So, does that then help decrease the amount of post-op? Not that people get a lot of post-op infections, but if you're not moving around like you're used to, you've set yourself up for pneumonia and for some other things. So, have you seen a decrease in some of those kind of complications? Absolutely. For example, with gallbladder surgery, one of the most common complications after the old-fashioned large right upper quadrant incision was a pneumonia. Yeah. That is essentially gone. I've never seen a patient with a pneumonia after gallbladder surgery. So let's talk about some specific diseases then. GERD. You have to tell me what, I have 4 letters, G-E-R-D. So correct. What is GERD? GERD stands for gastroesophageal reflux disease, or more commonly, heartburn. Okay, and there's a surgical procedure that will help heartburn? Yes, there is. There's a group of procedures called a fundoplication. A fundoplication means that there's a wrap of the fundus around the lower part of the esophagus and upper part of the stomach. The purpose of that is to decrease the amount of acid that would reflux up into the esophagus.
So at what point do I look at that as an option?
So in general, the things that we look for are people that have intractable disease. So intractable disease would mean you're on multiple medications and they at one point worked for you, but now are no longer working. If they never worked, then you might not actually have the disease.
So first you make sure that indeed someone has the disease. So you can you must be able to see something when you look down their esophagus, or I mean, would there be some kind of you know, would I be disfigured? Would I have, you know, lots of ulcers? I mean, how do you know?
So ulcer disease that's actually within the stomach is a separate entity, and thankfully these days we don't really have to worry too much about that because of the availability of over-the-counter medications for ulcers. The problem really is with the actual esophagus. If there's a lot of acid being washed up into the esophagus, you'll see that on an endoscopy by either redness or irritation. Sometimes you can have Barrett's esophagus, which is a precancerous condition that would either need to be followed, or you can actually have surgery, and Barrett's esophagus is one of the indications for surgery. In terms of structure, you might see a small hiatal hernia, and a lot of people with heartburn are told that they have a hiatal hernia. A hiatal hernia is simply just an enlarging of the hole in the diaphragm where the esophagus goes through into the abdomen. All of these things can be fixed by wrapping the stomach partially around the lower part to increase the pressure there. And you can also close the hiatus of the diaphragm tighter, which will help prevent acid reflux.
Anything from coming up through.
Correct.
Overall, do patients do well after the surgery?
Absolutely. The largest incision is about 1/2 of an inch, and we can do it with 5 small incisions.
Now, you know, I remember years ago somebody saying to me that, you know, we always have to remind our patients that it is sort of the same surgery inside, because people feel good within a couple days after the surgery.
Absolutely.
And so I think sometimes keeping them down a little bit is probably a challenge sometimes.
Sometimes, yeah. I do have a lot of patients that really enjoy being very active after their surgery and can't wait to get back to their physical activity. Sometimes I do have to remind them that they just had surgery. Yeah. I remember a story of a man that I did a hernia repair on who took his garbage out about a week after surgery, and he had a very strong reminder that he had just had surgery.
Because that was the first time he really did the
lifting.
Heavy,
right.
So that's a great segue into hernia surgery. I mean, I remember, you know, the laceration. Gallbladders were a whole different thing, but I remember, you know, at least you'd have an incision, people would be uncomfortable, they'd be in bed, you know, those kind of things. So how has this changed hernia surgery?
So hernia surgery, the classic hernia that a lot of people think about is groin hernias. We can do that surgery with, again, 3 small incisions. It's a same-day surgery like it's always been. The recovery is fairly minimal. The thing that I enjoy about that is I believe, and you can't really find anything in the literature about this, but I believe that the recurrence rate is less, and certainly the infection rate is less. We've never really seen an infection or a major infection of the mesh. We have to use mesh on all of these repairs, and I think the patients do really well afterwards.
Oh, you know, and because now people don't even stay in the hospital overnight, correct? Correct. All of these things are pretty much day surgery now, where it used to be 3-day hospitalization, and for gallbladders it would be 7 to 10 days, because I remember you'd have that T-tube, and you know, it was a big deal.
Right.
And now gallbladders, you do the same way. You go in with your, so you can actually see the gallbladder.
Yep.
And you snip it, and how do you get it out?
Pull.
Through that little tube?
Yes, when the gallbladder is removed from the liver, it can actually be drained within a bag that we exteriorize, and so therefore we can get it out, and all the stones along with it.
Well, thank you so much. We're going to take a few-minute break, and then when we come back, we'll continue our conversation with Dr. Cohen. I want to spend a little bit more time talking about hernias, and then, of course, we're going to talk about gallbladder disease, because we certainly see a number of patients who need to make the decision about having their gallbladder out. We'll be right back. Welcome back. Dr. Cohen, we were talking about hernias. first of all, you know, I was remiss because I didn't say, you know, I didn't ask you exactly what is a hernia.
So there are several different types of hernias. The most common would be a groin hernia or an incisional hernia from a previous open surgery. A hernia simply is a break in the muscle so that the internal contents of the abdomen can make their way to the outside world.
Internal contents, usually bowel, or it could
Actually,
be?
Thankfully, most commonly it's fat.
Oh, good.
So that's good, because if bowel gets stuck in a hernia, it can actually cause problems such as constipation, or if it gets stuck in the hernia, then it can actually strangulate and die.
But what if it's a hernia that kind of comes and goes? So when I lift, I feel, you know, I can feel or see something, right. And when I'm laying down, it's not there.
So most hernias can actually be seen on a CAT scan as an actual break in the muscle. You can actually follow on a CAT scan these days, just to remind you that the CAT scans that we have available at Marlborough Hospital are 64 slice scanners, which have essentially pixels that are 1 millimeter by 1 millimeter resolution, so you can see everything that's going on. And a hernia would show up as a break in the muscle.
And I'm just amazed that you can see that. Of course, I'm still amazed at how quick a CAT scan is done. You know, my old trauma days, you know, you would go to CAT scan, it would take a long time.
I remember those days.
Hours.
Yeah.
And now, you know, it's
matter of seconds.
Yeah, yeah. And you have a chest and a belly CT done in no time. So you, how do you do a CAT scan routinely, or only if you can't feel the hernia?
Correct, only if I can't feel the hernia, or if it were important in planning the actual surgery. So if a patient's had multiple previous operations, or if I had any concern about the location of certain structures, then I would be, or to size the hernia. That's what I would do.
So you said groin. Where else do you see hernias?
As I mentioned, the most common would be in the groin from heavy lifting or from previous surgery if you had a recurrence. And there's also a congenital type of hernia that happens in the groin. The next most common would probably be incisional hernias, where they happen along the lines of old incisions on the abdomen. After that, there's a smattering of other types of hernias that can happen.
Now, people can get them around their belly button. Is that usually related to surgery, or?
Well, so there's a couple of natural breaks in the abdominal wall. One is where we were connected to mom. That would be the umbilical hernia. The other is where the testicles descend through the inguinal canal into the scrotum, so boys can have inguinal hernias or groin hernias. The other breaks are all related to passage of other structures. So the esophagus can have a hernia around it. So that would be a hiatal hernia or a paraesophageal hernia. So
now you do these, you know, laparoscopically. Has it changed the way you repair them? You're still using what, mesh or grafts, or?
Right. It's a slightly different repair for most of these hernias, where we don't actually, most of the time I should say, bring the muscle back together. In the old days, when the muscle was brought back together, that caused a lot of tension and pulling, and because of that, patients had a lot of pain. We found out back many years ago, decades ago, that hernia recurrence is reduced by using mesh. And so we use mesh for all of these hernias as a matter of course these days, unless there's a reason to not use it, like either an infection or it's a very small hernia. The mesh would, for most of these hernias, would underlay the actual closure if we did it, or the actual defect. And it brings about a certain different type of problem rather than the original type of surgeries.
Now, are you seeing, any decrease in recurrence?
The data would say no, but I do believe yes. The data would say that the use of mesh brings the recurrence rate down from about 30 or 40% for most hernia repairs down to about 9 or 10%. For most laparoscopic repairs, that number seems to hold true. My personal belief, however, is that it's not just an easier repair if we have to redo it, but also that it happens less frequently.
That's, you know, I think there are probably a lot of people in our audience that are happy to hear that. So even if I go back to the same strenuous work, hopefully the recurrence will be less.
Will be less, yep.
Is it unusual to have hernias on both sides, or is it more typical on one side or the other? Or?
So it can be on both sides, absolutely, if you're talking about groin hernias. It typically patients will be symptomatic on one side and have an undiagnosed hernia on the opposite side. Again, more common in the younger patients because the older patients usually haven't gone through their entire life with the hernia. So,
and the symptoms that you have are pain, because when that fat gets trapped in there, it's painful?
Correct. It can be very painful. It can be intermittently painful with only heavy lifting. For groin hernias in men, the testicle can feel heavy at the end of the day without any actual groin pain. There's a whole host of different symptoms.
Wow. And the recovery time?
Generally, for an inguinal hernia, usually about 2 or 3 weeks, and then if your job entails a lot of heavy lifting, maybe 4 to 6 weeks to be safe. But the 2 to 3 weeks, which is the same for an open hernia, is spent rather than laying in bed being in pain. It's spent being up and walking and taking care of household chores.
And inguinal is groin. That's the same
correct.
thing. When we hear people have groin pulls, does that mean that is that muscular, or is that they may have a hernia that they've aggravated, or?
Correct. A groin pull can be simply a muscle strain in the groin. It could be it can be an actual hernia. It could also be something called a sports hernia, which is a little bit different, and that's more common amongst younger men, specifically soccer players, which is rather interesting.
So we're going to move on then to gallbladder disease, and I have to say, if there's one surgery that I think has really made a huge difference, it would have to be cholecystectomy, or removing your gallbladder.
Correct.
I do remember taking care of patients 30 years ago. It was at least a 7 to 10 day hospital stay. They would have their drains, and you'd watch for the bile to stop draining, and it was, people were sick. And as you said, it was a big incision that usually went from the front all the way around to the back. And my gosh, this has made such a huge difference. You have your gallbladder out in the morning, you go home at night.
Absolutely. In fact, when I had my gallbladder out, I was back to work on Monday, and I had it out on a Friday. So.
And I did the same, and I had to be to the high school halftime show to see my son in the band. I only went to see that and then went home that night.
Right.
But just the fact that I could be the first case of the day and at 7:30 be at a high school football stadium was just amazing to me.
Absolutely.
So that's one great thing that has changed. Now, do you ever begin the surgery, and once you see the gallbladder, you say, well, we're not going to be able to do it this way, we have to, do it open? Or how do you get a sense for that even before you start?
Well, the first thing comes with experience. The more gallbladders that you do, the better you are at judging whether or not this is going to be an easier operation or not. I would say that there are some patients that do allow their gallbladder disease to go on for a very long time, not knowing necessarily that it's their gallbladder, or knowing that it's the gallbladder and not wanting surgery. The longer you have symptoms of inflammation, the more difficult it will be to get out your gallbladder. Some of the things that when you look at the gallbladder immediately will tell you that this is going to be difficult are a lot of adhesions to the gallbladder. Specifically, not so much the fat that gets stuck to the gallbladder. Adhesions is scar tissue in response to inflammation. But one of the things that gets stuck there that can be very dangerous is if the duodenum, the first part of the small intestine as it leaves the stomach, if that gets stuck to the gallbladder, that can be very difficult and dangerous to take care of. But generally speaking, the gallbladder usually can get taken away from all of those adhesions, elevated away from the important structures, and taken out safely. There's one specific area that we have to be very careful in, and that's called the triangle of Callot. And that's where we have to dissect out the duct that goes to the gallbladder and also the artery that goes to the gallbladder. If that dissection is difficult, then sometimes you would have to convert to an open operation.
So how do we diagnose gallbladder disease these days?
So a lot of it is by symptoms. So the typical symptoms would be pain after eating, pain on the right side underneath the ribs, pain that wraps around to your back or up to your shoulder. Those are symptoms of biliary colic or symptomatic cholelithiasis. Other symptoms can be severe pain and fever. That would be cholecystitis or inflammation of the gallbladder.
So you can have a stone or just have an inflammation of your gallbladder with well, I guess you have stones in your gallbladder, but sometimes those stones can get out.
So yes, the gallbladder disease becomes dangerous when the stones get out of the gallbladder and travel down the duct, and they can cause pancreatitis and other issues like cholangitis. Mm-hmm. The best way to diagnose a gallbladder disease is with an ultrasound. Sometimes we need a CAT scan as well. And there are other tests that can be done too for other non-stone diseases, such as a HIDA scan with CCK. Sometimes just a plain HIDA scan will tell you whether or not there's cholecystitis.
Now, do you have to have gallstones to have gallbladder disease?
No.
Or, so you can have an inflammation without stones?
Correct.
And if you don't have stones, you still should have your, depending on how much pain you're in. Is that really what guides?
It does. I didn't have any stones, and I had my gallbladder out because of chronic pain.
The amount of pain after. Yeah. It's pretty impressive pain when you get it a few times. I just have to ask, how do you get the gallbladder out?
So the gallbladder typically gets put into a bag. We bring the bag up to one of the incisions, and we can either, if there's big stones, have to crush the stones, or if it's no stones, just slide the gallbladder right out. And
then you stitch up the little. Do you even put stitches in anymore? The little, how many incisions do you make?
So it's 4 small incisions. The largest is around your belly button usually, and that's about maybe an inch long. On the inside, to close the duct and to take care of the artery, we use a combination of clips for the major structures, and for the minor structures we use electricity to cauterize the liver bed. For the muscle, there's a stitch right at the belly button. Apart from that, everything else is absorbable, and typically I use glue to close the incision so that patients can get into the shower and feel good about themselves the day after surgery.
That is amazing, and I'm sure that there are people in our audience who had their gallbladders taken out, what, 25 years ago?
I'm very sorry.
Yeah, I know. That was, I just can very early in my nursing career, remember taking care of patients.
I'll be happy to take care of those hernias.
I know, that come after the surgery.
Right, exactly.
So we've talked about, GERD and the treatment that you can do surgically to help people who have chronic heartburn. We've certainly talked about gallbladders and hernias. For the most part, those are elective, but you can use the surgery to take out appendix.
Correct.
And are there other emergency type surgeries that you can?
So gallbladders can sometimes be an emergency.
They certainly can.
Hernias can be an emergency if they're if something is stuck or incarcerated.
Yeah.
I've done some laparoscopic procedures for trauma. I've done a couple of other types of operations for the small bowel, the large bowel. Even some perforated diverticulitis can be taken care of laparoscopically. But by and large, it's mostly for elective surgery because of the nature of how we're doing things. Thankfully, these days, most people are not coming to the hospital with surgical emergencies like they used to in the past.
That's great. So all the surgeries that we talked about today, are those available at Marlborough Hospital?
Yes, everything that we spoke about today is available at Marlborough, with the exception of some of the workup for the acid reflux, the gastroesophageal reflux. That needs to be done at UMass in a specialized center where we talk about manometry to look at the function of the esophagus and the pH testing to see exactly how much acid is coming up. But everything else can be done at Marlborough.
Well, thank you so much. Believe it or not, our 30 minutes is up. I told you it would just fly by. I just want to say again how thrilled I am to have you joining the Marlborough Hospital staff. And I think today we walk away with a sense that, minimally invasive surgery is certainly becoming more the gold standard these days. But it's really your responsibility to work with the patient to decide what is the best option.
Correct.
Based on what kind of condition I bring to the arena. And, I think we can all feel very comfortable with your expertise and that you're going to guide our patients to make the best decisions for them. So again, you're going to be in Southborough at 28 Newton Street, and welcome to the team.
Great. Thank you very much, Candy.